Welcome to Medical Rehab Matter. In this episode, our guest is Dr. Carl Sandin, AMRPA's first Chief Clinical Officer, and he'll be talking about the hows and whys of this new role. And joining us is AMRPA President Kate Beller. I'm Patricia Sullivan, Director of Communications for AMRPA, and your host for this episode. We want to thank our podcast sponsor, Bioventus, for its support, and we'll start after this short message. Bioventus, a Bioventus rehab company, develops medical technologies which include neuromodulation systems, robotic systems, and software-based therapy programs that provide functional and therapeutic benefits for individuals affected by central nervous system disorders and orthopedic injuries to help return patients to active lives. Learn more at bioventusrehab.com. So hi, Carl. I'm glad you could join us today.
Well, thank you so much for inviting me, Patricia. I'm glad to be here.
And hello to you too, Kate.
Hi, Patricia. Always enjoy being on the podcast. And Carl, looking forward to talking with you today.
So first, thanks to both of you for being here. I really appreciate it. Let's launch in. So Carl, can you tell us a little bit about yourself?
Sure. I'm a physiatrist. I went to medical school at Northwestern and did my rehab training at TIR in Houston and have been in practice in a wide variety of settings throughout California and the Midwest. And most recently came back to California, where I'm doing some locum tenens work and helping AMRPA in this new Chief Clinical Officer role.
So what is a Chief Clinical Officer?
Most healthcare trade organizations have someone who is a Chief Clinical Officer, not always a physician, but the overarching role is to bring a clinical voice to health policy. As part of fleshing out the role and responsibility, I've talked to people who do a similar kind of job, for example, at CARF, the Commission on Accreditation of Rehabilitation Facilities, and the American Hospital Association. This role endeavors to ground the staff and the leaders on achieving meaningful, high-quality clinical outcomes and support the volunteers and employees in the missional aspects of service delivery.
And can you give some examples of what you're going to be doing for AMRPA in this role?
As most of us are well aware, payers like the federal government continually expand their reporting and measurement programs, hopefully to guarantee value in their payments to hospitals. Having a clinician as part of the policy evaluation team should help AMRPA's chances of ensuring that information requested is efficacious to obtain, transmit, and respond to, focuses on the needs of the person served and care providers, not on the wants of bureaucrats, and reflects our functional ethos in medical rehabilitation. As we know, bedside staff and rehabilitation organizations don't have the bandwidth for yet another aspect of information that's superfluous. Reducing the burden of daily work is one tactic to decrease burnout, and I hope to play a role. I'm also going to provide some ongoing education and training for AMRPA members. I've just written a one-page summary on venous thromboembolic disease prevention and medical rehabilitation settings that's derived from a summary of a recent peer-reviewed article. I hope that physicians, nurses, therapists, administrators, and quality management staff from our constituent hospitals will find this summary useful as they evaluate what to do at their hospitals to reduce harm from blood clots. It's almost ready, and it'll be out soon, and hopefully our readers will read it and find out if it's useful. Let us know how we can improve the products going forward so that we have the right information to share with team members about how they can provide excellent quality at the bedside and in their organizations.
And I just want to say it's really possible that by the time this airs or is released, the email announcement of this role and that report that you were referring to may already be in some of our listeners' inboxes. So they should be aware. Just check that out. So how did this role come to pass?
AMRPA has always felt like a professional home to me. In my work as a physiatrist and a rehabilitation hospital president, AMRPA has been my go-to place for education and training, operational support, and camaraderie. So as I pass to the years of my professional life more dedicated to service and paying back rather than striving, I'm looking for that next promotion. I contacted AMRPA leaders and asked if there might be a non-stipendiary position where I could offer something useful to the medical rehabilitation field. This is not a full-time position, and I'm going to continue to work part-time at the bedside. Hopefully, by having one foot in the hospital and the other in policy, I'll be able to bring some meaningful insights to AMRPA.
Can I just add that we have, I think our staff team is a great team. We have 2 lawyers and a data analyst. And I think just being able to tap into someone like Dr. Sandin to say, help us explain the issue, help us put, your hospital experience onto paper and in front of policymakers in a way that, always puts patients at the forefront and explains if there's a burdensome regulation or policy that's, taking physicians away from the bedside or therapists or nurses away. Again, we can put that in a context that drives action, that makes our asks meaningful and powerful. So and it's not that we haven't been able to do that previously with Dr. Sandin and a host of AMRPA physician and clinical leaders, but having that in-house resource now, I think has just been a really great addition to our policy arsenal this year.
That's wonderful. And I think we do talk about the patient care all the time. And I think this is a great addition. I can see how it can be very helpful. So, Carl, what will success look like for you in this role or for AMRPA?
To me, this position is all about catalyzing AMRPA volunteers. It's a field-driven organization that punches above its weight in great part because individuals are committed to the work of medical rehabilitation, and they write to Congress, and they intently view new mandates and review articles. They work hard on AMRPA committees and take the time to learn at AMRPA meetings, through publications, and hopefully even through podcasts like this one. So as the breadth and depth of our volunteer engagement expands, and as new members and participants come to the fore, that'll be great. Of course, we want to see policy and presence victories in areas such as physician reimbursement, the 60% rule, recognition that rehabilitation hospitals are distinct rather than just a part of an amorphous clump of the post-acute continuum, prior authorization, and patient experience. There are so many things to work on, and I want to thank again the volunteers that really spend so much time helping AMRPA be a great organization.
How will this role continue to enhance AMRPA's relationship with other stakeholder groups and as well as clinical leaders within the rehabilitation space?
Well, as most of us know, medical rehabilitation is kind of a small space in the entire healthcare continuum. So it's really important for us to link together to magnify our voice, small though it sometimes can be. So we've already started some conversations with the Association of Academic Physiatrists. That's the group that represents PM&R training and PM&R academic faculty. They're very involved in graduate medical education, training young physiatrists, and we hope one of the outcomes of that training will be that those newer physicians will want to work in inpatient rehabilitation settings. There's a lot of places for them to go and help people with disabling conditions, but AMRPA is committed to success of inpatient rehabilitation, and physicians are an important pillar in that success. So if we have physicians that choose to have their practices in inpatient rehabilitation, that helps AMRPA in its work. AAP is a research organization, and AMRPA, through its strategic planning process, is realizing more and more the importance of research. So we look forward to learning from AAP what research looks like in the medical rehabilitation sphere. Moreover, AAP leaders are oftentimes leaders of academic rehabilitation hospitals. So we hope that through conversations, they come to value membership in AMRPA to see what benefits there are to AMRPA membership for academic medical centers. I've also had some great calls with the American Congress of Rehabilitation Medicine leadership. The ACRM leads interdisciplinary practice. If you want to know how physical therapists, nurses, doctors work together and collaborate, go to an ACRM meeting, you'll see it in action. It's really important to our field that we have that kind of camaraderie at the bedside for the benefit of the patients that we served. Like AAP, ACRM has research as part of its mission. So again, we look forward to hearing more from them about the benefits of health services research that unassailably demonstrates the utility of inpatient rehabilitation hospital. We'd like to see article after article published in the literature that talks about how great patient experience and patient outcomes are at inpatient rehabilitation hospitals, and that those unique settings are of most benefit to patients with disabling conditions. It's also great to have a relationship with CARF, the Commission on the Accreditation of Rehabilitation Facilities. I'm a program surveyor for that organization, and many of us know it is laser focused on promoting quality, value, and optimal outcome of medical rehabilitation services through its consultative accreditation model. I've also been in contact with rehabilitation hospitals that are classified by the Center for Medicare Services as Rehabilitation Innovation Centers under a Senate Act in 2022. And we're trying to see what the outcome and what the benefit of that particular act has been for those organizations. So I'm looking forward to having ongoing conversations with myriad rehabilitation service organizations, patient groups, Partnership for Quality Measurement, for example. It's really a great time for us to lead in medical rehabilitation, but also learn from our partners.
That sounds so all-encompassing of the field. It seems like you're already interacting with nearly everybody, and you've just started. So it's kind of exciting for the future.
I think it is. I kind of have the gift of gab, so I can get out there and say, hey, I'm Carl from AMRPA. What's your role at whatever? And through that interaction, we learn so much about clinical services, about how to run organizations. And so, again, with AMRPA really being a leader in medical rehabilitation, it's going to be a wonderful opportunity for us to hear more and more and lead more and more in this space.
And no pressure. And we have not discussed this in advance, but when we need a co-host on a medical issue, you might be who I call on. So people might be hearing from you more. Just a fair warning to you.
Okay.
No pressure. So do you have any final thoughts that you want to share with us?
In addition to having a medical doctorate, I have a Master of Public Health from UCLA. And one of my professors, Dr. Carl Volpe, was a policy wonk before he came out to Los Angeles to teach and worked for the National Governors Association. And he always said there are three spheres that we need to focus on in healthcare: quality, access, and cost. And then he would go on to say, pick two, because he was sure that it would be impossible to have a healthcare system of high quality, universal access, and affordability. So I think in the medical rehabilitation space, AMRPA can lead to ensure patients who need medical rehabilitation can readily access high quality healthcare services that are successful economically for them, for insurers, and for the hospitals that provide care.
Well, I want to thank you for taking the time today to talk with us. And I'm really excited about what the future holds for this role, with you in this role for AMRPA. And I want to thank you. Thank you very much for being here.
Well, thank you again for the invitation, Patricia. Always glad to talk to you. And anyone who is hearing this and has a comment or question, cco@amrpa.org. So Chief Clinical Officer, abbreviated cco@amrpa.org is my email address at AMRPA, and I'd love to hear your thoughts.
And this will be, I'll include it in the podcast description. So anybody listening through any platform should be able to get a hold of it. Thanks so much. Bioness, a Bioventus rehab company, develops medical technologies to support recovery for people living with the effects of stroke, brain injury, MS, and other conditions. The Bioness portfolio of products includes functional electrical stimulation systems such as the L300 GoDrop foot system and the H200 wireless hand rehabilitation system. The Bioness Integrated Technology System, BITS, is a software-based therapy platform that uses an interactive touchscreen display to challenge, assess, and track vision, cognitive, motor, and balance deficiencies. The Vector, Gait, and Safety System is a ceiling-mounted robotic dynamic body weight support system designed to accelerate physical rehabilitation of patients with severe gait or balance impairment. Bioness' combined portfolio helps drive efficiencies and improve patient outcomes for healthcare providers. Learn more at bionessrehab.com. This has been Medical Rehab Matters, a podcast by the American Medical Rehabilitation Providers Association. Special thanks to Diamond sponsored Bioventus and Platinum sponsors PAM Health and Select Medical. To learn more about inpatient medical rehabilitation, visit us at amrpa.org.